To go now to the Q&A with the panel. I've had quite a few questions through, so I will start at the top. And obviously, Muir, as our first speaker, you had some of the first questions, so I'll maybe give you one of those before we move on to some of the other speakers. The first question comes from Jagdeep Grewal. Hello, Jag. Nice to hear from you again. Who says, talks about spending a year designing a value model using data and AI for major conditions within an ICS, that being accepted as ICS strategy. However, the CFO saying no, they recognise the long-term positive impact, but it cost in the short term. So the question is, how do we get around short-term focus in the NHS, where basically CFOs have to balance the books in every year and they can't make the longer-term investments? So Mia, can you comment on that? You're on mute, Mia.
Yes, I would use the North Circular Road as the example, that it was designed in 1943 in the middle of the war, the bombs were falling. And I think, Claire, this is something, I've just dropped a note to the Academy of Medical Royal Colleges, who produced a very good report on protecting resources and promoting value in 2014, but only doctors were involved. And what they did when they designed the North Circular Road was that London County Council got a small group of people and gave them protected time to think about the future. And I think this is what's needed in the ICSs are the key organisations to get the leaders of 2034 and 2044. And this is a very Japanese approach that I've learned over the years from people called Nonaka and Takeuchi. You set up let's set up a 2034 team in every ICS. Because when you do that, the old guys like me say, oh, well, it's never going to happen anyway, hoping for retirement coming along. I've changed the name of retirement to Renaissance, by the way. But the old people don't do it. But the young people, we've got to say to the youngsters, look, you're going to be running this in 2034, 2044. And one day a week, you put together a team of maybe 12 people in Liverpool ICS or whatever, and they become the transformation team. They still keep their day job on. They need someone senior like John to be the lead, but you build a transformation process. So I think yes, short term, I can only imagine the pressure you people are under, but you've got to find time to plan the North Circular Road or plan D-Day. In the middle of war, you have to create time to think ahead.
Thank you, Mia. We're all benefiting from and enjoying your Renaissance, so long may it continue. I'll move on. So I've got some other questions for you, Mia, which I'll maybe come back to in a moment. But I'll move on to one for Claire. So Claire, the summary is, do you think benchmarking in the NHS helps or hinders engagement with clinicians and other staff?
I think it entirely depends on the benchmarking. I think, you know, there's always going to be a role for benchmarking because it goes back to the clinical variation or unwarranted variation that Muir talked about before, which not only has an impact on value and productivity, but also on clinical outcomes. So I think understanding what we need to measure and what is appropriate in terms of measurement and any data quality issues, and engaging with the people who are in receipt of that information to understand from them what the right metrics are from a benchmarking perspective. I know that every single organisation in the NHS will all say that they're special and they are different to anywhere else, but I do think that if we ask clinicians, they will be able to point to areas where other organisations provide similar services in similar circumstances. So I do think there is a role for it, but I think it's about choosing the right one and engaging with clinical operational colleagues to ensure that we're measuring the right things. I think one of the most really powerful piece of benchmarking work that I've seen in recent years was the work that was done, I'm trying to think of the name of it, and John might be able to remember, it was led by clinicians and clinical teams, and they looked at specific specialties. Right, GIRFT, great, getting it right first time, the GIRFT, yeah. program. And I think why that was really powerful, it was the first time I saw clinical teams really listen and hear from other clinicians where their service could improve, or where they were doing really great things that they could share more about. So I do think there is a role for it.
Thank you, Claire. And it's great to see in Julian Kelly's recent public paper, his public board paper that came out in the middle of May, talking about expanding GERFT to cover additional disciplines and areas, which is a great sort of clinicians for clinicians effort. So good to see that continuing. Okay, so this was a question for anyone, but I'm going to pose this maybe first of all to John. I know it's a topic close to kind of the heart of Alder Hey, and then Dilshad, maybe if I could ask you to come in after as well to give your perspective from Vietnam. The question says, whilst all this great work is underway, part of me wonders how we can move to a new NHS model of care, from one based on illness treated in hospitals to one based on wellness, prevention and community-based care. Otherwise, the same challenges will continue year on year despite everyone's best efforts. So, how do we move essentially from treating illness to, promoting health? John, do you want to maybe address that one first of all with your perspective from Alder Hey?
Yeah, it's a really tricky one, and I think probably plays a little bit to the question Muir picked up previously, actually, around the natural short-term cycle versus the need to really invest in a shift left that actually starts to focus on prevention. And I'm not sure there's a simple bullet for this, because otherwise we'd have done it previously. I think a couple of things we've been very reflective of, and just playing out in some of the work I was describing with 2030. I think what's clearer than ever now, I think, in the health system is that unless we shift that paradigm, we're in big trouble, I think. So the sort of the burning platform really of prevention, I think, is swamping us now, and actually is meaning that we're if we don't tackle it, I think it's almost moving out of that. I don't think anyone ever would have said a nice to do thing, but in terms of the day job, it probably at times felt like that. So I think that's one thing for me. How do you create a sense of urgency now around this? And then the second piece really for me is goes back to those business models and mechanisms of reward. We need some real innovation in that space, I think, and it's really challenging to do that when we need to treat more people because they're waiting far too long. And the simplest way of delivering that, and probably has been proven to be the most effective, is to have a payment by results type model. But at the same time, that almost promotes the treatment models that Muir's described, that maybe even whether that's over treatment or I think almost prevents the ability to innovate and use funds in a different way. So I think if I could have two areas I think that we would need as a service to push forward on, but where we're definitely thinking, one would be prevention now being a burning platform, and then secondly, how do we collectively start to think differently about money flows so that it makes sense to do the right thing?
Thank you. It's sort of a strategic take on the North Circular analogy that you were talking about earlier, Muir, isn't it? How do you move the whole system onto a different footing in that sort of way? Dilshad, what's your view from Vietnam? I mean, obviously, you've led companies in Malaysia, in Saudi Arabia, in Vietnam. What's your sense on that move to the front foot?
I think, Mark, firstly, it's the design itself, how we manage our models of care. Very focused on, to date, especially, we've been focusing a lot on illness. We've been always looking at non-communicable diseases, diabetes, hypertension. Not many systems have looked at charting the entire journey of a demographic population from the start. For instance, people who come from a specific region being tracked right from the start about how they would progress from childhood right all the way up to adulthood. And I think this resonates with what John is saying, that a child can be tracked right from the time she's coming into teenage life all the way out till she gets into postmenopausal, and that's along the way where your screening works out and everything else as well. That's one. The second, I think, as John touched as well, is incentive. And payers have to be involved in this whole switch or the paradigm. I've had conversations with many different countries in terms of the UAE or even Saudi Arabia, and the only way you can incentivize wellness is to make sure that you offer, or payers offer, access in terms of being able to go and understand what your wellness is, instead of going to a hospital when you're unwell and getting paid or getting reimbursed for it. That's a key shift that's required in terms of where an importance of payers comes into play to generate the intensity of change. Third, obviously, is accessibility, and we keep saying this. Sir John said in his comment that we need to create a digital community, and this digital community is not going to be just within healthcare professionals. There are influencers within community who can generate enough awareness in terms of wellness, etc. It's an influencer-led world, and definitely when there are influencers who show wellness works instead of illness, then that works. And the best tool for this is always digital.
Very good. Muir, I'd like to come in on that.
Yes, I think the NHS should actually stick to the disease service and concentrate on diagnosis, acute care, and starting the right treatment. But for both prevention and for living with long-term conditions, it's a different model is needed, where the citizens have to take responsibility, supported, as Dilshad was saying, in communities. I mean, it's 11 years since I've had a myocardial infarction. I've had 600 boxes of pills, but not one word from the NHS about diet or exercise or how am I feeling. First 3 months were great, you go to the gym, but after that, not one word. And the research we've done shows something like only 14% of people with mental health problems get anything other than pills. But that doesn't mean we've got to appoint more psychologists and more GPs, because they're not there. And we've got a project, and I'd like to hear from any hospitals who are interested in discussing it with us, where we're aiming at the 30%, let's call them least activated is the jargon, over 60-year-olds, and saying to them, listen, sunshine, as we say in Glasgow, you've got a contribution to make too. You're coping, you're making heavy use of A&E and primary care, but we need to reach out to people in a different way. And we're looking at ways in which we can reach people. Interestingly, the football clubs are very interested in this. I don't know if that's the case in Liverpool, Claire or John, but they're starting to change the way they work and seeing they're adding social value. So I think we need a different, as I say, the NHS, I hope it would keep diagnosing my myocardial infarction well, stick a stent in and get me started in the right treatment. But after that, I'm responsible. But I need support of the way Dilshad was talking about, and the idea of a digital and a local community. And people, we call it buddy care, people helping one another.
It's perfect for a thinking differently webcast, right? Certainly on that theme. I think we've got time for one more question and then we'll close. And Claire, I'd like to direct this one to you, if that's okay. The question says, thank you for sharing your thoughts on addressing the productivity challenge. What would you say CFOs should do differently in the boardroom to deliver the step change in performance? I'll mute, Claire.
Give me a minute to think about an MCC. In the boardroom, that's a very good question. I think it's a slight cheat answer. I think there is something about working with exec colleagues before the boardroom conversation to ensure, not in a choreographed way, but to ensure that people are owning the right bits of the agenda, and that the CFO is bringing in the right colleagues around the table to have the discussion in board. I think the board reports traditional board reports in the past, and I'm certainly reflecting on, you know, the ones that I've presented to boards over my however many years as a finance director, you know, they're not going to cut it in the future. So what does the new finance report look like that does focus on productivity and value in a different way? And I think that would then open up the right conversations. So there's probably a number of other things, but I can't immediately bring to mind, but they'd be the key things for me. I think a lot of it is the way the exec team works together on the solutions before coming through to the board meeting itself.
Thank you, and I'll take that as a link to a final message from you all, if I can ask for that, and maybe in the order that you've spoken today. So Samir, Claire, John, Dilshad, and that message is around what is the one thing you would urge every leader to do when they leave this webinar or they've just watched it on recording in order to improve productivity? So Samir.
Think less about productivity and much more about value.
Very good. Claire.
Review the metrics that you're using to engage with people.
Thank you. John.
I would give people confidence that you mean to do the right thing in this space by doing something that reduces their burden now.
Thank you. Dilshad.
I think for me, it's going to be constant innovation and design in the sense of understanding the models. And most importantly, I'm going to resonate with Claire that it's going to be a one-team approach, not just finance. It has to be clinicians and operators as well in that sense.
Very good. Thank you very much. Well, with that, I think we will bring things to a close. I would just like to say to all of those who attended, thank you. Please don't forget to fill in the feedback survey. It should just take 2 minutes of your time, and it'll help us improve our future events and understand what topics you would like to see covered. Thank you very much for joining. Thank you again to all of our speakers. Please do look out for the recording and the summary of the questions and answers, which will be on the webpage soon. Apologies for those who we didn't get to answer in the time available. The next webinar is on the topic of can the NHS address health inequalities, and the topic of narrowing health inequalities overall, with some interesting links there to what Muir was talking about. That is on Tuesday, the 3rd of September at 12:30, so another lunchtime session. We look forward to seeing you there. I hope you have found this informative, and thank you all very much indeed.